Grand welcome to INICET Recall, May 2024, Speed Institute. So, coming to first question, a 13-year-old boy presented with nasal obstruction, recurrent epistaxis for last 6 months. So, the key word here is recurrent epistaxis. So, out of the given options, what is the most appropriate diagnosis? So, antroconal polyp, yes, it can present in children, but not with recurrent epistaxis. Coming to angiofibroma, it's a diagnostic. Future for JNA is recurrent epistaxis. Allergic rhinitis very rarely presents with recurrent epistaxis. Nasopharyngeal carcinoma can have epistaxis but not in an adolescent boy. So now you need to understand when they give recurrent epistaxis, there are three differential diagnoses for this. If they give recurrent epistaxis, there are three differential diagnoses. One, in a child, it can happen due to antroconal polyp or any infectious polyp can cause this. Any infectious polyp can cause in a child recurrent epistaxis. Epistaxis is nothing but bleeding from nose. It can happen due to any infective condition. One of the infective conditions that can cause in a child is antroconal polyp. Now the same question if they ask in an adolescent male, the answer as in this question would be adolescent male, its answer would be juvenile nasopharyngeal angiofibroma. Now, if they have given old age, so more than 50 years, 60 years with recurrent epistaxis, then don't forget to mark nasopharyngeal carcinoma as a diagnosis. So, three questions. Most common cause of recurrent epistaxis in a child would be nose picking. Most common cause of recurrent epistaxis nasal obstruction in a child is antroconal polyp. Most common cause of recurrent epistaxis nasal obstruction, so there is a mass which is causing obstruction. In an adolescent male, then it is JNA. In an old age, recurrent epistaxis can happen due to nasopharyngeal carcinoma. In all these, there will be one additional feature that the child or the patient will have a recurrent otitis media that requires grommet insertion. So coming to features of juvenile nasopharyngeal angiofibroma. Juvenile nasopharyngeal angiofibroma is a condition of adolescent male patients. Average age of onset is around 13 to 15 years. Most common site of origin for this juvenile nasopharyngeal angiofibroma is spinopalatine foramen. Spinopalatine foramen is the place which connects nasal cavity to the nose or nasal cavity to the pterygopalatine fossa. Pterygopalatine fossa. So nose is connected to pterygopalatine fossa through this foramen called spinopalatine foramen. Spinopalatine foramen. So in any case scenario, if they give you recurrent epistaxis with unilateral progressive nasal obstruction, like in this case you can see in the scan, usually this is unilateral. Sometimes it can cross opposite side and block the choana entirely. That is extensive juvenile nasopharyngeal angiofibroma. In those patients, you can have bilateral. Otherwise, unilateral progressive nasal obstruction with recurrent unilateral epistaxis, always think of angiofibroma as a diagnosis. There will be overexpression of IGF-2 and the CET scans finding which tells you it is JNA is nothing but Holman-Miller sign. So what is this Holman-Miller sign? It is nothing but anterior bowing of posterior maxillary sinus wall. So if you see the red arrow in the picture of CT scan, so it is pushing this posterior wall front. Here the posterior wall is intact. Why it is happening? So it is happening because of filling of mass in the pterygopalatine fossa. Pterygopalatine fossa is filled up because of mass. That is the reason it is causing a sign called Holman-Miller sign or antral sign or anterior bowing of posterior maxillary sinus wall. So this sign is called Holman-Miller sign or antral sign. So it's almost pathognomic of this juvenile angiofibroma. Is there any use of MRI? Answer is yes. MRI can tell you whether it has gone into orbit, it has gone into CNS. Surgery is treatment of choice. Surgery is treatment of choice. But before surgery, since it's a vascular lesion, you need to embolize. So embolization is required in these patients before surgery. Embolization definitely should be done in these patients before surgery. Embolization is definitely need to be done. So coming to question 2, which of the following structure passes between superior constrictor and middle constrictor? If you see, there are dehiscences from skull base to almost esophagus. Skull base to almost esophagus. So in the second picture, if you see, it explains from base of skull till superior constrictor. There is a gap which transmits structures called ALAP. So many guides, many other centers might be explaining Tala and Thalap, whatever they want, they are telling. Ultimately, so it's an anatomical question. You can't change the anatomy. Whatever they describe in their videos is utterly wrong. Tensor villi palatini doesn't go through this opening. Underline this point. This was wrongly mentioned in many pre-PG entrance guide books, which is wrong. Tensor villi palatini doesn't go through this sinus of Morgagni space. So what is sinus of Morgagni? Sinus of Morgagni is the space between skull base and superior constrictor. This opening is called sinus of Morgagni. So what are the structures which pass through that? A stands for auditory tube, L stands for levator villi palatini, A stands for ascending palatine artery, P stands for palatine branch of ascending pharyngeal artery. Tensor villi palatini doesn't form a part or doesn't go through this opening. It's only the levator villi palatini. It's mentioned in the picture. Okay. So this picture and this picture, they mentioned only levator villi palatini, not the tensor villi palatini. So that's wrong. So ALAP, that's nothing but auditory tube, levator villi palatini, ascending palatine artery, pharyngeal branch of ascending pharyngeal artery. Now, the space between superior constrictor here and middle constrictor here. So, there is again a gap. So, it transmits between superior and middle. There is ninth nerve. We call it as S9. The space between superior and middle transmits or structures passing through that include S9. S is for stylopharyngeus, 9 is for glossopharyngeal nerve. So remember it as S9 goes through or between superior constrictor and middle constrictor. The structures which pass through gap between middle constrictor and inferior constrictor is, so remember there is superior laryngeal nerve and superior laryngeal artery. In that superior laryngeal nerve, we have two branches, EBSL and IBSL. So internal branch pierces through the thyroid membrane and goes into the pharynx inner layer. External branch of superior laryngeal nerve directly goes and supplies the cricothyroid muscle. So external doesn't come into the opening, it's internal branch. So again, second question in the previous exam, where does this internal branch stay? So it stays at the apex of, it supplies below the apex of pyriform sinus. This is pyriform sinus. So whenever you are dealing with this pyriform sinus pouch like thing, if you anesthetize any nerve here, that nerve is internal branch of superior laryngeal. So therefore, the gap between middle and inferior constrictor transmits internal laryngeal nerve, which is a branch of superior laryngeal nerve, and superior laryngeal artery. And in the same way, from the lower border of inferior constrictor to the esophagus. So you have rectal laryngeal nerve, and rectal laryngeal nerve is also called as, I told you superior is separate. Now it's also called as inferior laryngeal nerve. So it is located down, so it's called inferior laryngeal nerve. In the same way, the artery which goes with the inferior laryngeal nerve is inferior laryngeal artery. So easy to remember, sinus of Morgagni is between base of skull and superior constrictor. The structures which pass are A, L, A, P, auditory tube, levator palatal, ascending palatal artery, pharyngeal branch of ascending pharyngeal artery. Okay. The gap between superior and middle transmits S9. Superior and middle transmits S9. Stylopharyngeus and glossopharyngeal. The gap between middle constrictor and inferior constrictor transmits superior laryngeal artery and superior laryngino. Its internal branch of superior laryngino. Remember it as all the superior go through middle and inferior. All the inferior goes through inferior constrictor, between inferior constrictor and esophagus. So remember inferior here and superior here. It's easy to remember LAP S9, superior and inferior. Okay. This question is easy to answer. So like this, you can answer with the mnemonics. So question 3, which of the following is not a typical feature of allergic rhinitis? So Dennis Morgan line, yes. Allergic shiners, yes. Allergic salute, yes. So it is Otto Viragut sign. So what is this Otto Viragut sign? So first of all, it is seen in a condition called depression with psychiatric disorder. There is inverted omega shaped appearance of the upper eyelid, which is angulated upwards and backwards. So it's almost like a omega only, or like your laryngomalacia epiglottis, it becomes. So you have a depression. This is the fold which forms, and the sign is called Otto Viragut sign because it is described by Otto Viragut. The answer wrong is Otto Viragut sign. But what is this Dennis Morgan folds? So this, you can see the black lines below the eyes. They are called allergic shiners. Shiners. Then what is this child doing? It is called allergic salute. What is this called? It's a horizontal line called allergic nasal crease. So shiners, salute and nasal crease. And along with that, you find lines below the eyes, like folds like this. In the next picture, you can see multiple black discoloration here, that is shiners, and you can see multiple folds under the eyelid, that is called as Dennis Morgan lines. This is a salute, allergic salute. This is allergic crease or nasal crease. This is cobblestone mucosa. And important point apart from Dennis Morgan lines. So this is classical Dennis Morgan lines are these. You can see the horizontal folds below the eyelid. So the difference between folds and shiners is something very like a blackish discoloration under the eyeball. Folds are like multiple folds, infolds of the skin below the eyelid. Important point, pale, boggy turbinates. Yes, they are definitely enlarged in allergic rhinitis, but they will be pale. They will be pale. They will be pale. So pale, boggy turbinates are classical for this. In hypertrophic rhinitis, you see mulberry hypertrophy of turbinates. Classically, here you have pale, boggy turbinates. There will be enlargement, bogginess, but it is pale. It is pale. So that's the thing. That's a differentiating point. Which of the following is not associated with serous otitis media? It resolves on its own. Yes. It is a bilateral condition. Yes. Most commonly seen after cold. Yes. But AD type of graph is seen on impedance audiometry is wrong. So if you see B type of impedance audiometry is seen in patients with serous otitis media. Serous otitis media. So now what is the cause for this otitis media diffusion or serous otitis media or secretory otitis media? So there are many names: SOM, OME, NSOM or glue ear. So to explain these terms, or it's also called as mucus deposition, so it is called mucoid otitis media. No. So non-suppurative otitis media, because it's only a fluid, it's not pus, so it is called non-suppurative otitis media. Non-suppurative is because it's a fluid, it's not a pus. Why it's called otitis media with effusion? It's not transudate, it's effusion. So effusion without pus. So it is otitis media with effused fluid. Why it is called serous otitis media? There is serous discharge or a clear discharge, so it's called serous otitis media. Why it's called secretory otitis media? Because goblet cells secrete the mucus, so it's called secretory otitis media. Why it's called mucus otitis media? It is called mucoid otitis media because it's a mucus that is getting deposited there, so it's called mucus otitis media. If the mucus stays for long, it forms glue type of discharge, so it's called a glue ear. It's called a glue ear. So these are the other names for otitis media with effusion: serous, secretory, mucoid, glue ear. Whenever there is a gas deficiency because of eustachian tube dysfunction, the prime problem would be eustachian tube getting blocked because of cold, resulting in eustachian tube dysfunction. So the patient will develop middle ear gases absorb. So there will be hypoxia in the middle ear. This causes release of TNF alpha, which goes and causes mucosal hyperplasia along with EGF plus IL-13 factors. Finally, the cilia or the ciliated epithelium of middle ear metaplases to have more of goblet cells and hyperplasia happens. So you all know that goblet cells secrete a lot of mucus. So therefore there is this persistent mucus overproduction which is monitored by IL-10. So this is a factor why there is mucus. So you can see a clear tympanic membrane behind with air bubbles, that is mucus secretions behind this. In this type, if you do a Putron audiogram, you get a conductive type of hearing loss. But if you do impedance audiogram, you get normal is A type, but here you get B type of gram. So A again is divided into A as normal, and AS and AD are another important questions. So D stands for discontinuity. So it is nothing but ossicular discontinuity. S stands for sclerosis. So you see AS type of graph in otosclerosis or tympanosclerosis. So any sclerosis causes a low compliance curve, that is AS type of curve. And same way, a fluid in the middle ear causes a flat type of curve like this. So that is flat type of curve. That is B type of curve is seen in fluid in the middle ear. Even serous otitis media, chronic suppurative otitis media, ASOM will all have B type of graph. Then I told you cause of this collection of mucus is eustachian tube dysfunction, which is nothing but a negative middle ear pressure because gases are absorbed. There you see C type of graph. C type is nothing but, if you imagine normal distribution curve, you will have 0 at the center in the same way here. So you have the all curves pass through this 0 point, but one and only eustachian tube will have a peak and a trough before the 0 point. It's nothing but negative pressure curve. Negative pressure curve. So coming to tympanic membrane pictures, this is a normal tympanic membrane. It's a acute otitis media or a reddish erythematous drum. It is effusion behind the drum, that is OME, which we discussed, and there is a perforation in pars tensa, so it is chronic otitis media. So serous otitis media looks like this, secretory otitis media also looks like this, acute otitis media looks like this with congested drum. Chronic otitis media without cholestoma is nothing but pars tensa perforation. Chronic otitis media with cholestoma is pars flaccida perforation, and tympanoid retractions are predisposition for cholestoma disease. So coming to question number 5, a 7-year-old child presented with hard of hearing and along with that sensorineural hearing loss. Which of the following is not a part of management? Classroom accommodations correct, cochlear implant correct, hearing aid correct, but not adenoidectomy and bromide. So logically, if there is adenoid hypertrophy, then only you will do adenoidectomy. You will not do adenoidectomy in all cases. The same way here also, when required, you will do adenoidectomy, not in all cases. So answer B is wrong. So now theoretical answer for this is, in a sensory or hearing loss patient, you first opt for counseling, sensory management technology, and communication and intervention. So sensory management, you will counsel with information along with psychosocial adjustment, because patient needs to be in the community. He needs psychosocial counseling and informational counseling. Then second part of counseling is giving instructions how to use the hearing aid. And third part is giving training for usage of this, that is called perceptual training. This includes speech reading training, frequent communication partner training, communication strategy training, and auditory training. So it's not alone the sensory management that is important. Instruction and counseling, which form part of counseling, is very important, and communication training is very important, apart from sensory management, which includes hearing aids, cochlear implants, and frequency modulation systems. So this is a holistic approach including all these: counseling, communication, and intervention, along with sensory management. Together they are used for sensorineural hearing loss. Next question: a 42-year-old obese male presented with disturbed sleep and daytime somnolence. So clearly this is obstructive sleep apnea because of three reasons. First thing is disturbed sleep, usually it happens in the night time, along with daytime excessive sleepiness in a obese male. So all of the following are correct regarding this except apnea with awakening, apnea with fall in saturation, apnea with hypercapnia, but not pharyngeal muscle contraction. So why this is not the answer is, so usually you have NREM sleep followed by REM, that is rapid eye movement sleep, non-rapid eye movement sleep. So in NREM you have 1, 2, 3 and few books tell it 4 phase, and then it is followed by REM. In REM you will have lot of dreams, and along with that there is muscular hypotonia. Hypotonia of musculature, that is laxity of musculature causes, that is relaxation of musculature causes obstructive sleep apnea. So whenever he is in REM sleep, he will have hypotonia. There will be increased the relaxation of muscles that cause increased OSA. Whenever he comes back to NREM sleep, again he will revert back to normal pharyngeal tone. So there will be contraction of musculature which reduces the OSA. So the option C is wrong. That's why it happens in episodes. So he will not be in OSA all the night. Why this happens in episode? There will be apnea because of pharyngeal muscle relaxation which happens in REM sleep, followed by normal NREM sleep with contraction where there is decreased OSA. So patient will have apnea because of obstruction and he will get awakened. Before awakening, there will be fall in saturation and buildup of carbon dioxide. So option A, B and D are related with OSA. Option C, the pharyngeal muscle relaxation should be there to increase the, if there is hypotonia or less tonic contractions only, patient will have increased OSA. If there is more contraction, there will be reduced OSA. Flabby mucosa causes more OSA. So option C is wrong. After periodictomy, patient has lower lip palsy alone, which was noted. Which of the following structure got damaged during surgery? Parotid duct. So if it is parotid duct damage, it is closely related to buccal nerve, where you cannot do a balloon type of cheek. If it is main trunk, it's not the lower lip alone. It would have been mainly concentrated on eye branch, that is temporal or zygomatic branch. So it's not temporal because eyes, they didn't comment, vision is good. That's what we have to assume. So next, option D is the correct answer. Out of exclusion, option D is the correct answer. But had it been marginal palsy, that would have been more better answer, because cervical branch supplies platysma. This function, averting the lower lip, happens in platysma supply. So this function is due to cervical branch. Marginal mandibular nerve is a branch which supplies the lower lip. Marginal mandibular will come like this and turn towards the lower lip. So lower lip palsy can happen mainly due to marginal mandibular branch. Upper lip is predominantly supplied by buccal branches, buccinator and zygomatics. So zygomaticus also supplies orbicularis oculi. Temporal band supplies orbicularis oculi, frontalis, and corrugator supercilium. So the answer here would be more apt to be marginal mandibular. Since it is not there in the options, you need cervical branch as an answer. So coming to 8th question, a 46-year-old patient came with facial palsy complaint. On examination, there is lower motor neuron palsy and there is no radiological clinical findings. How will you treat this patient? So based on history, you don't have any etiology for this. So therefore, it is idiopathic and particularly described as lower motor neuron palsy. So most common cause of lower motor neuron idiopathic palsy is Bell's palsy. So try to understand this point. You don't do straight away facial decompression or remove context mastoid foramen or electrical stimulation. Always try to treat the patient with medical treatment and acyclovir. If the patient responds, it's okay. If the patient doesn't respond, then you need to do electrical stimulation. If electrical stimulation warrants decompression, then you can perform decompression. The order is medical management, the steroids with acyclovir, followed by electrophysiological or stimulation test. Then if also, then you can find out if the patient should undergo facial or decompression for improvement, then only you do that. So how will you treat this patient? This patient you need to give prednisone along with acyclovir. Whatever may be, it may be paresis, it may be palsy. So initially the treatment would be prednisolone with acyclovir. But if it is delayed acute palsy, that's more than 14 days, but it's acute only more than 14 days. Then you need to think of whether he can improve or not. There you have a chance of doing something else. But here in this case, you need to opt acyclovir and steroids as a treatment because this is a first line therapy which you prescribe for Bell's palsy. Why acyclovir? So HSV is one which is associated with Bell's palsy. So that's why it gets treated with acyclovir. Why steroids? Since the virus causes neural edema, to relieve that edema, you are giving steroid therapy. Clear? So the answer for this question is D, which signifies that you need to give steroids and acyclovir as a first line treatment. Thank you.